name is Dr. Aarti Campo. I am a cardiologist at Nuvance Health. Today, we are going to have a discussion about women and heart disease. Joining me today will be someone who has personal experience with heart disease, and I also have a number of experts in the field so that we can discuss symptoms that women have with heart disease and methods and ways you can do to prevent development of heart disease. I'm going to open with Wendy, who has had a heart attack. Wendy, tell us about that day. What do you remember?
Mine actually started the day before with severe pain down my right arm, but I also suffer from fibromyalgia. And being the day before Thanksgiving, I just chalked it up to a bad flare. That continued through the night until the next day, where then nausea hit, or again, pass it off because I'm in so much pain, until I got jaw pain. Then I knew something was definitely wrong.
So at that time, Wendy, what were your thoughts when you started to develop the jaw pain? What was going through your mind?
Well, I used to do home health care years ago, and one of the women I was helping out had had a heart attack, and she had mentioned jaw pain. So when that started, I thought, this is more severe. This is not my fibromyalgia. So I took an aspirin, and then we called an ambulance. If I hadn't known about that woman, I don't know if I would have been, I might have continued with the turkey. You know?
Right. Now, what was it like once you learned that you had had a heart attack? What was going through your mind at that point?
It was very scary, but almost a little surreal also, because I had absolutely no chest pain. Just the pain in the arm and my jaw and a little bit of nausea. So it was frightening. I had to go alone. Nobody was allowed to go with me because of the coronavirus. So actually it was very frightening. I didn't know what was going to happen.
So it sounds like a very scary experience.
Yes.
How are you doing at this time?
I'm doing good. Working on losing weight. I quit smoking.
Perfect. That's all fantastic. What advice do you have for women listening to us today in regards to heart disease?
I would say listen to your body. I was very exhausted in the days leading up that I just kind of ignored because, well, it's the holidays, you have things to do. So listen to what your body is telling you and stop and listen to it. You have to put yourself first sometimes, or I wouldn't be here.
Wendy, thank you so much for sharing your story. I'm going to now open it up to Dr. Rajeev Narayan, Director of Endovascular Services at Vascular Brothers Medical Center, to tell us a little bit about what a heart attack is and what are some symptoms that women have as opposed to men.
Thanks so much, Dr. Campo. Wendy, thank you so much for sharing your experience. I think that your experience that you're giving our population that's going to be hopefully hearing this is something that everyone needs to hear. Number one, one of the reasons why the mortality rates for women when they have heart attacks or they have coronary artery disease or blockages in the arteries of the heart is because of the fact that it's such an under-recognized phenomenon in women as opposed to men. First of all, as should be known, coronary artery disease is the #1 cause of mortality in women. It's something that's really not well recognized by women. And when you ask, actually, only 1 in 3 women actually recognize that coronary artery disease is, in fact, the leading cause of mortality. Most people think, 2 out of 3 women actually think that cancer is the #1 cause of mortality, when in fact, a cardiovascular disease as a whole actually leads to a greater mortality in women than all cancers combined. And I think that's something that's just so important to note. Women in general predominantly present with symptoms that are very atypical. Similar to what Wendy was describing here, most women don't present like men do, which is how the classical literature and how advertisements, everyone else has presented things. people recognize that elephant on the chest discomfort symptoms, which is so classical of heart attacks, and only the minority of women actually present with that classic findings. In fact, most women present with atypical features such as fleeting symptoms of shortness of breath, sometimes palpitations, a feeling of nausea, pain that goes into just the jaw or the arm alone, or even sometimes right-sided arm or chest discomfort, things that many times physicians would look at and say, hey, these are atypical features of cardiovascular disease, but in fact could be demonstrative of having a heart attack, or what we call a myocardial infarction. That's the medical term for a heart attack. As a result of this, women, traditionally speaking in medicine, undergo far less testing for cardiovascular disease. They're far less oftentimes, they far less often have coronary angiography, which is the testing that we do invasively to look at the heart arteries, and oftentimes are less often the patients who would get therapies such as stents and revascularization treatments like bypass surgery. And then to add to this, Dr. Campo, I think you kind of alluding to this, which is women are far more likely to develop their symptoms and their problems later in life. Usually because of the protective effects of estrogens, younger women are far less likely to develop cardiovascular disease type symptoms. And as a result, on average, women present with their symptoms of heart attacks 7 to 10 years after men do, which also leads to the fact that women at that age usually also have other comorbid conditions, which increases their risks when they do develop their symptoms of heart attacks.
Dr. Narayan, can you tell us a little bit more about treatment of acute heart attack? So, you know, a woman's having jaw, chest pain, what should she do at that time?
Of course. So number one thing is if anyone's experiencing any of these type of symptoms, obviously you should come into the emergency department and be evaluated aggressively or seek care with an appropriate provider in the cardiovascular field who can advise further. In that acute setting, typically speaking, a doctor will evaluate you and perform appropriate diagnostic testing, including an EKG or an electrocardiogram, which looks at the electrical rhythms of the heart to ensure that there's no major changes. Blood tests are usually drawn to ensure that there aren't elevations of a heart enzyme called a troponin, which can sometimes indicate that you might be having a heart attack. Depending on the results of those studies, along with other testing that can be performed in that acute setting, a decision could be made whether you're going to be someone who's going to be getting medical treatments and maybe some non-invasive testing like a stress test or echocardiographic imaging, or if you're somebody who's going to be moving forward into getting invasive testing, and that's something that someone like me, an interventional cardiologist, would be involved with. And that procedure typically involves something called a heart catheterization procedure or a coronary angiogram. And what that entails is placing a small tube, typically in the wrist artery, called the radial artery, or in the leg artery, and we can snake up a small tube to the heart arteries and inject contrast dye into the arteries of the heart, allowing us to illuminate the arteries to look for blockages. If indeed blockages are discovered, we can sometimes fix that in the same setting using a series of balloons, catheters, and stents. And in rare instances, if that's unable to be fixed with those procedures, or if we feel that you may be served better with more advanced therapies, surgery or even other therapies could be recommended as well, complemented by good medication treatments.
Thank you for telling us about that in detail. Next, I'm going to turn to Sandy Biolo, who's a nurse practitioner with our Danbury team at Nuvance. She has been in the practice of cardiology since 2004. Now, Sandy, I understand that there are other types of heart disease that women are also prone to. Can you tell us about those a little bit?
Yeah, so I'm discussing a bit about the risk factors for heart disease for women. So we often talk about traditional risk factors: diabetes, smoking, obesity, physical inactivity, hypertension, hyperlipidemia. And what I've been looking at lately are some of the non-traditional risk factors that women have, specifically the risk factors that occur during pregnancy, such as gestational hypertension, preeclampsia, gestational diabetes, preterm delivery, and low birth weight. These all increase women's risk. So gestational diabetes is considered hypertension that occurs after 20 weeks gestation, blood pressure greater than 140/90, and severe hypertension is greater than 160/110. And this has a greater risk of preeclampsia. And preeclampsia then has more long-term consequences besides cardiovascular risk, developing hypertension, diabetes, and then their cardiovascular risk is multiplied 4 times greater with these kind of processes. Preterm preeclampic women are really at an even higher risk. Gestational diabetes, this is newly diagnosed diabetes beyond the first trimester, and these women have a significant risk of developing diabetes, which again is a major traditional risk factor for women. Preterm delivery, which is defined as birth less than 37 weeks, and those even less than 32 weeks have a doubling of cardiovascular risk. And then, of course, low birth weight also increases the risk. The other thing I'd like to talk about a little bit is autoimmune disorders, specifically rheumatoid arthritis and systemic lupus. The male to female ratio for these disease processes, specifically rheumatoid arthritis, compared to male to female, so 2.5 to 1, and systemic lupus 9 to 1. So women are affected by these disease processes more often. And again, they are at increased cardiovascular risk when they have these disease processes. And to speak a little bit about cancer, we've made great strides with cancer and cancer treatment, which now leads us to have over 12 million cancer survivors. But then the long-term survivors actually represent the largest and fastest growing patient populations for premature cardiovascular disease. So sometimes these advancements cancers have now affected our cardiovascular risks. This disease could pre-exist the cancer therapy, or it can be caused and exacerbated by it. The key thing is women and breast cancer. 1 in 8 women will be diagnosed with invasive breast cancer. So the common treatments for these types of cancers are chemotherapy and radiation. And both chemotherapy is mostly cardiotoxic, and radiation could lead to coronary disease. It causes fibrotic changes to the heart valves and also to the heart muscle. So I think that's very important that women are aware of this when they're talking to their healthcare provider. And then depression is also a big one. Depression affects women worldwide 2 times greater than men. And this is definitely being recognized as a risk of development of CAD. And these differences are emerging as early as adolescence. So, younger population of females are diagnosed with depression, and this is just putting them at a greater risk. So going forward, I think it's important for women to know their health history and bring that to their primary care providers, their cardiologists, to really inform them, what their pregnancy-related issues may have been, if they had cancer, and what kinds of treatments they received. And it's really important because the current cardiovascular risk scoring systems do not include this. They don't include the autoimmune, they don't include the pregnancy or the cancer. So these women, if they're put in a scoring system, will be looked at as low risk. But if you add this in, they are high risk and they need to be watched closely and treated appropriately.
So Sandy, just to summarize what you were saying, I understand you're saying that so if a woman has gestational diabetes or other cardiac risk factors with pregnancy, those can affect her health years later. So she should seek care with a cardiologist. And it seems that you were saying a similar sort of message for women who have had breast cancer and treatment for breast cancer, which is very necessary, but it seems like years down the line, they are at risk for developing heart disease. Is that right?
Correct.
So, and you're also telling us that a lot of these risk factors don't get calculated into when a doctor looks at someone to see what their risk of developing heart disease is. So again, it's very important that women be aware of risk factors that put them at higher likelihood of developing heart disease and seek appropriate medical care.
Yes.
Now, Thank you so much. Now I'm going to turn to Ann Lucas, nurse practitioner with the Heart Center, who has a doctorate in nursing practice. She's been with the Heart Center for the past 15 years. She's going to cover some of the more traditional risk factors for heart disease that Sandy alluded to. Ann, I'll leave it to you.
Hi, everybody. So in cardiology, there are certain patients that with other medical conditions that stand out to us as far as who's at higher risk for developing coronary disease and what likelihood they have of other cardiac issues. So of those things, we pay attention to blood pressure, very important one. Sandy gave us some guidelines as far as where your blood pressure should be, but there's been studies out in recent years that show even lower numbers. If your number is normally 130 over 80, if you can get your blood pressure down to 120 over 70, there's less likelihood of cardiovascular events over the course of several years. So controlling your blood pressure is a really important one. Diabetes as well. A lot of times in healthcare, people say for diabetics, it's not a matter of if, but when they develop coronary artery disease. And there are some primary care providers who will send patients to us for cardiac screening just based alone on the fact that they're diabetic, even if they don't have any cardiac symptoms at all. It's important to keep your blood sugar under good control and stay on top of that. But also not a bad idea to undergo cardiac evaluation because we know that the incidence of plaque deposit in the arteries is much higher for diabetics, and they are also less likely to experience symptoms than non-diabetics. Monitoring your lipid panel is another important factor, and especially pay attention to your LDL, the low density lipoprotein. It's a smaller particle, and the belief is that it can deposit into the walls of the artery and create plaque buildup more so than some of the other factors. So ideally, we like it under 100 and prefer it to be more around 70 or less. For people who do not have known coronary disease, for people who do have a diagnosis of coronary disease, we really want them to be pretty tight on those numbers and aim for less than 70. Anybody who has smoked ever, I know my college roommate was a social smoker who only smoked on Fridays and Saturday nights when she went out, but not during the week. Any history of smoking at all is also a contributing factor. And even if you think that you didn't have a significant smoking history, it does play a role in the development of coronary artery disease, and also people with exposure to secondhand smoke. There is some literature out there now also showing that it can contribute to plaque deposition in the arteries.
Now, Ann, you had mentioned screening. Have there been any advances lately in screening to help detect early heart disease in women?
Mm-hmm. So I think the basic screening that most people have heard of is having an electrocardiogram or an EKG. Everybody should have one by the age of 40. And usually it should be part of your yearly annual physical exam. A test that I think is fantastic that has been in use for probably the last about 20 years is something called the coronary artery calcium score, or calcium score as it's often referred to. And this is a very quick CAT scan that's done as a screening test. Typically for people who are not experiencing any symptoms. And what it does is, as people develop plaque buildup in the arteries, calcium particles will deposit into that plaque. This is a very quick CAT scan that is looking for the presence of any of this calcified plaque in the arteries. As a screening test, it does not tell us if there is early plaque deposition in the arteries, but if there's something that has been there for some time, it'll start to have calcification occur to it. And that's what this calcium score is looking for. So a 0 would be a normal test, not finding the presence of any calcium particles. And as the numbers get higher, the greater the volume of calcified plaque in the arteries. And with this screening test, we actually have had people who've come in who've had no symptoms at all. They get the test. We find a very high number up in the thousands, and it saved them from having a heart attack, and in some cases have even had bypass surgery without ever having any kind of inclination that this was going on.
I want to thank you all for being here. I think this was a great session in educating women on symptoms to look for and things that you can do to advocate for yourself and prevention strategies. Thank you all for being here with us today.